Good morning. Imagine being the physician attending for a patient who shows to your hospital with a gunshot wound to the chest. You promptly take him to the operating room. The following day, the patient is liberated from the ventilator. Over the course of the next several days, he grows frustrated with the process required to recover from his lung injury, and he demands that his chest tube be removed and that he be discharged from the hospital. As his surgeon, you encourage him to stay until discharge is safe, reinforcing all the possible complications that could occur if the chest tube is removed too hastily. Nonetheless, the patient accepts his risks and insists on being discharged home to care for his children. Scenarios such as this one are more common than you might think, and they pose a dilemma for both patients and surgeons, as there is no standardized follow-up for patients who leave the hospital prematurely. I'll begin by introducing the term leaving against medical advice, its implications, background on the topic. Then I'll share with you top reasons why patients choose to leave against medical advice, both nationally as well as within my institution. Then we'll discuss surgeons' attitudes regarding patients who leave against medical advice, and finally, propose things that we can do to prevent patients from doing so, as well as the associated incidents of negative outcomes. While there is no standard definition for what it means to leave against medical advice, it's an instance where a patient chooses to leave prior to medical clearance, and this is any patient who has medical capacity. Capacity is defined as the ability to use and understand information to make a decision, and then to communicate the decision that's been made. Thus, any person who is under the influence of drugs or alcohol, or anyone who's disturbed by psychiatric or metabolic disorders, by definition, does not have capacity and cannot choose to leave against medical advice. These patients should instead be treated for their conditions, and sometimes this requires a court order. In 2011, Holmes and colleagues proposed criteria for what it means to leave against medical advice, a standardized definition. This includes the criteria that the request be triggered by the patient prior to the complete medical workup, treatment, or procedures being performed. It also implies that the procedures, workup, and treatments cannot be performed on an outpatient basis or are highly unlikely to be performed on an outpatient basis, and that the patient have medical decision-making capacity. In the surgical population, several risk factors have been implied for leaving against medical advice, and these overlap with the medical population. These include mental health disorders, younger age, substance abuse, male sex, and low socioeconomic status. In the trauma population specifically, African American race and stab injury mechanism have been identified as unique risk factors for leaving against medical advice. The implications of patients leaving against medical advice extends beyond the obvious concerns regarding treatment for their medical conditions. Physicians have conveyed increased distress and dissatisfaction in their ability to care for these patients due to their loss to follow-up, presentation with uncontrolled pain, and a lot of times complications secondary to untreated or undertreated medical conditions as a result of their premature hospital departure. Studies have also shown that these patients are stigmatized and as a result may be less likely to follow up. Systematically, premature hospital departure is associated with a 56% greater than expected cost as a result of increased readmission and complications. Of the 1% to 2% of patients who leave the hospital against medical advice, 20 to 40% represent for readmission, and as many as 10% die. What is more concerning is that this rate of incidence continues to rise from 264,000 in 1997 to nearly 500,000 in 2011. So this begs the question, can surgeons reduce the incidence of AMA discharges, readmissions, and associated complications? And with a little bit more information, I thought this to be a reasonable possibility. The first step in my methodology was to objectively identify all the patients who left AMA in a given year. I then sought to identify reasons why they leave against medical advice and to see if any of these reasons were something that we could act on or improve. I then surveyed surgeons regarding their current practices and outlooks on patients who leave against medical advice. I took the information I learned and educated the surgeons regarding the study findings and corrected any misconceptions that may have existed. And finally, implement standardized documentation and protocols regarding an AMA discharge policy for my department to prevent negative outcomes. In order to reassess the efficacy of this study, I will then go back a year later and re-identify the number of patients who leave AMA to see if the risk has in fact decreased. In order to identify the patients who left AMA in 2021, I surveyed the CLIC application, specifically reviewing data from the general surgery and trauma populations. The results show that 56 patients left AMA in 2001, of which majority were Caucasian males who were actively using tobacco, alcohol, or recreational drugs. Majority of these patients were admitted with traumatic injuries, the most common of which was blunt thoracic trauma. Following blunt thoracic trauma, the most common injuries were intracerebral hemorrhage, blunt abdominal trauma, obstruction, and abscesses. This was followed by penetrating abdominal trauma in third place. The electronic medical record chart review was performed to identify the most common reasons why patients chose to leave against medical advice. These were identified to be, first, personal reasons that the patient chose to leave, including attending to family, work-related matters, etc. The following reasons tied between choosing to leave the hospital to pursue substance abuse, unclear reasons, patient dissatisfaction due to prolonged wait time, and patient exhibiting violent behavior, likely under the influence. Finally, surgeons were surveyed regarding their current practices and outlooks on patients who leave against medical advice. 20 participants responded to the survey, majority of whom were male between the ages of 31 to 40, with less than 5 years of practice. When asked how they respond to a patient's request to leave against medical advice, 45% of responders asked the nurse for the reason of the patient's departure. 45% actually spoke to the patient either in person or over the phone. 45% of the responders informed the patient that complete financial responsibility for the hospital stay may befall them if they leave prematurely. And only 5% asked the nurse to proceed with AMA paperwork without any further questions. When asked what their follow-up is for patients who leave AMA, 65% of providers provide follow-up information, of which 45% also provide medication on discharge. 15% actually create a follow-up appointment for the patient, and 20% of the respondents said they provide no follow-up information or medication. When inquired about their perceived most common reasons for patients leaving AMA, the top was poor health insight of the patient, followed by patient being belligerent or under the influence, dissatisfaction with care, and needing to attend to work-related responsibilities. Those providers who told their patients that complete financial responsibility will befall them if they choose to leave AMA were actually propagating a misconception that was studied by the University of Chicago, where of 526 patients who left AMA over a 10-year period from the university, only 4.1% were refused payment for their hospital stay. However, the reasons for refusal were largely administrative, and there were no cases of payment refusal made solely on AMA discharge status. Nonetheless, 68.6% of residents and up to 44% of attendings believed that insurance companies deny payments when patients leave against medical advice. So this misconception and other findings will be educated to surgeons during an oral presentation, as well as the study that will be published to set a platform for other institutions to follow. And finally, to implement these findings in a standardized template will be created in the electronic medical record to indicate processes to be taken when a patient wishes to leave AMA and provide appropriate documentation. And finally, a departmental discharge protocol will be implemented for patients who wish to leave AMA. So in summary, physician introspection into patients' concerns and perspectives is paramount for the formation of a trusting relationship and compliance in the treatment of a surgical and trauma patient. Standardized practices help reinforce normative culture and decrease the variability that contributes to negative outcomes. And despite the common thoughts to the contrary, the AMA form does not legally protect the physician. However, good decision-making and documentation will. I thank you for your time and attention, and I welcome any questions.